Good morning, ladies and gentlemen. First, let me thank the organizing committee of Paedgastrocon 2022 for inviting me to deliver this lecture. I'm speaking to you from all the way from Sri Lanka, Colombo, and bringing you the well wishers from the University of Colombo and Sri Lanka College of Pediatricians. So we are supposed to speak on constipation. I have first a clinical history, which I would like to go through with you. A 4-year-old boy presented with a history of reduced bowel frequency and hard stool for 6 months duration. The mother also says that the child refuses to pass the stools in the potty and stiffs his body when there is a desire to pass the stools. On examination, the clinician found a well-grown child. The abdominal examination reveals a large fecal mass in the lower abdomen. The rest of the system examination is unremarkable. I'm sure in your clinical life, all of you must have seen somebody like this who is suffering from constipation. Now, the biggest question in managing these children is to define constipation. What is childhood constipation, ladies and gentlemen? There had been several definitions of constipation in this world literature. Now, it's like three blind men describing the elephant. Some people would describe hard stools as constipation, while others describe infrequent motions. Like gentleman in the blue suit, somebody would say rectal fecal mass is constipation. However, in reality, none of these things are equal to constipation. Constipation should be defined according to Rome criteria. The Rome criteria was formed because a lot of disparities between definitions has led to real confusion. So the group of pediatric gastroenterologists developed these criteria and it's now in its fourth iteration. In Rome 4 criteria, you must have 2 or more of the following criteria. Defecation frequency less than 2 times a week, fecal incontinence at least 1 a week, retentive posturing, painful or hard bowel motions, large diameter stool, fecal mass in the rectum, and criteria should be fulfilled at least once per week for 1 month without any organic disorders. So that is how you define constipation. So according to this definition, the child that we describe has clearly functional constipation. So what is the epidemiology of childhood constipation? What is happening across the world? Let's have a look. This is the global map of prevalence of constipation according to Rome criteria. You can see India here, right? The data from Vidyut Bhatia published in Indian Journal of Pediatrics. So the constipation global prevalence is somewhere around 9.5% according to all Rome criteria prevalences. So now let's look at the prevalence in outside Asia. You can see bit of a high prevalence in Brazil as well as significantly high prevalence in Nigeria. Now let's look at Asia, what's happening around us, right? Hong Kong has very high prevalence and Taiwan has very high prevalence in one study, and even our own country, Sri Lanka, has 15.4% of children suffering from constipation. So we have this question actually whether the epidemiologic epicenter is shifting from west to east, because initially, in about 20 years ago, constipation was thought to be a disease of the Western world. Now it is not so, because a lot of you can see a lot of epidemiological studies being conducted in Asia, and we found higher prevalence than some of the Western data. So we need to be very conscious about it, whether we have more constipation than in the Western world. So the next question, what is the etiology of childhood constipation? So what led to constipation in that 4-year-old child is the next question. So organic causes such as hypothyroidism, hypercalcemia, celiac are very rare among children with constipation. right? Intestinal diseases like neuronal dysplasia, neuropathies, and myopathies are extremely uncommon. In my 20 years career, I have not seen any. So what do they have then? They have, ladies and gentlemen, functional constipation. So what's the basic pathophysiology of functional constipation in a younger child? So look at this diagram over here, right? This is the normal rectum. Feces come into the rectum. Rectum dilates. At one point, you get the urge to pass the stools, and they pass the stools, right? Now here, of course, what happened in certain children is due to fear or pain or some other reason, they start to withhold stools. And look at, if you start to withhold stools, stools get accumulated in the rectum, right? Now you're not going to pass this. And what happened next is interesting. Colonic mucosa, rectal mucosa, it's designed to absorb water. So the mucosa absorb water here, and this become a rock hard fecal mass, which occupies the rectum. Now, when the child start to pass this, it causes excruciating pain, and that leads to further inhibition of passing stools and develop withholding behavior. Now, with the withholding behavior, the fecal mass become larger and larger. So it goes like a cycle. So that is the main pathophysiological reason for children, younger children especially, to develop functional constipation. What are the risk factors for functional constipation? So, effect of age. Now we can see younger children have higher prevalence of constipation than older children, according to some of our data which we published about 10 years ago. And look here, males have higher prevalence than females. In addition, as we all know, several studies have shown the poor intake of dietary fiber is a risk factor for constipation. This study from Hong Kong, Lee et al. Very clearly showed that, in Asian data, that we have a problem. If they have low fiber intake, that's a very clear risk factor for childhood constipation. Junk food. This study is from Hong Kong, and they showed children who eats a lot of junk food have higher tendency to develop functional constipation. What are the psychological risk factors? So exposure to stressful life events lead to constipation in children. This is our data from Sri Lanka. We showed that separation from best friend, failure in an exam, severe illness in the family, loss of job of parents, and frequent punishment at home, and living in war affected area are sort of psychological stresses that could lead to constipation in children. Now, this shows the very important point of association between child maltreatment and constipation. We found all three major forms of child abuse, physical, emotional, and sexual, are associated with uh, childhood constipation. And this study is again very important. We assess the psychological maladjustment uh, in school children and correlate its possibility of association between maladjustment and constipation. What we found is this personality trait like hostility and aggression, negative self-esteem, negative self-adequacy, emotional unresponsiveness, and negative worldview. All these things are very clearly associated with constipation. So putting everything together that we have discussed, look at this cartoon, right? So we have behavioral disorders, psychological disorders, and lifestyle factors which can affect, which can lead to constipation. In this side, you can see what we have described: abuse, trauma, stress, and maternal and paternal factors like depression, anxiety in mothers, and overprotection from parents, and other physiological factors that disrupted microbiota, genetic factors, and colonic dysmotility. So the constipation is in children is due to collection of these factors, and they react with each other to develop childhood constipation. How should a child with constipation be evaluated? I think it's very important. The clinical evaluation is the key to diagnosis. Therefore, we need to know exactly what we are going to do. How do they present? They present with, features of constipation, like, reduced stool frequency, fecal incontinence, stool withholding, straining, sometimes bleeding PR due to anal fissures, abdominal pain and distension, and sometimes with urinary incontinence. So when they come with these things, we need to take a very good history, and I cannot overemphasize it. Clinical history is the clue to the diagnosis. So you can see here, this is the these are the components of the history that you need to take. So you need to take a detailed bowel habits story, and needing stool frequency, consistency, incontinence, and all that, and withholding behavior, and then go into family history, dietary habits, assess the dietary fiber and water intake, and past medical and surgical problems, certain surgical conditions like repairing of anorectal malformation and Hirschsprung disease can be associated with constipation. And as I said, psychological history, stresses, abuse, and all that, and the social history. Those things are very important points in the history. In the examination, which is very important to get the growth parameters right and check for dysmorphic features, then go for abdominal examination, check for distension, scars, fecal masses, and perianal and rectal examination whenever necessary, and lower limb neurology. So all that gives you a very clear picture of your child, the patient that you are going to assess for constipation, and then check for red flag signs. There are several red flag features, and if they are there, you are probably not dealing with a child with functional constipation, and maybe a organic disorder, maybe underlying organic disorder is the cause for constipation. Therefore, you need to be very careful and don't miss these things like features of a spinal bifida, loss of perianal sensation, and all that. And something like developmentally, if the child is having developmental delay and constipation, it may be due to a lot of neuronal problems that they have. So you need to be very careful to check all these red flag features. When they are not there, you can say this child is having functional constipation. How should the diagnosis be made? Constipation is a clinical diagnosis, ladies and gentlemen. Don't ever forget this very important point. If don't have to have tons of investigation to diagnose childhood constipation. This is very clear. If you have a history and if you have very good examination, if the history and clinical examination shows that the child is fulfilling clinical criteria for ROM 4, then you can diagnose constipation. Now, what do we do? Most of clinicians tend to do investigations. They tend to do plain abdominal x-rays, thyroid functions, all these allergies, celiac screening, all that. And actually, there is no place for such investigations in day-to-day management of constipation. Now, a lot of people do plain abdominal x-rays, commonly ordered, right? Idea is try to and assess the amount of fecal loading in the colon and the rectum. Now you can see this X-ray, you can see some fecal matter accumulating in the colon, right? Now, there are a lot of scoring systems. At least there are 3 scoring systems to assess this fecal loading in the rectum. But none of the clinicians use these things. Even if they use, these systems have intra-observer and inter-observer unreliabilities. Therefore, it is very difficult to assess, and this assessment is not very useful in day-to-day clinical management of constipation. Very similarly, it's a very knee-jerk reaction from pediatricians to order a thyroid function test to detect hypothyroidism. But remember, ladies and gentlemen, hypothyroidism, majority of children with hypothyroidism have normal bowel habits, right? And in this case series, Bennett and co-workers have found, they have done a lot of thyroid function tests, and only one child had constipation as the presenting feature. So it's the validity of thyroid function test in diagnosing constipation and finding underlying hypothyroidism presenting as constipation is not very valid actually. So colonic transit studies, this is very useful, especially when they are not responding to treatment. So you use radiopaque markers or radionuclear scintigraphy or virus motility capsule. You can calculate total and segmental colonic transit times and are useful in the diagnosis and management. So if the colonic transit time over 62 hours is very suggestive of significant constipation. These are the pictures, and you can see here in this X-ray, you can see rectosigmoid retention, whereas in this X-ray, you can see pancolonic dysmotility. Now, what are these are old stuff. Now, what are the new diagnostic tools that we have? One such thing is high definition colonic manometry. You can, anorectal manometry, you can provide information on sphincter function, rectal sensation, anorectal reflexes, and all that. It is, you can three-dimensionally create the rectum and see whether there are any abnormalities. So this is a useful test, but it is not very widely available across the world, right? The other one is high resolution colonic manometry. It provides information on high amplitude propagatory contractions, cyclic motor patterns, and colonic slow waves initiated by intestinal cell of Cahill. So these things will give you an idea of what is happening, what physiological changes have taken place in these children who are having functional constipation. But we don't do these things in ordinary, every child who comes in. They are reserved for children with refractory constipation. Now, how should they be managed? This is the management paradigm for constipation. Now you can do several things in our order of priority. So first thing you can do education and lifestyle modification. Then you can go for behavioral treatment and laxatives and rectal evacuation. Then physiotherapy and biofeedback is available, neuromodulation, surgical interventions. All these things can be used and according to the clinical condition of the child. So education and demystification is the most important thing. You should sit down and talk to your patient and teach them the prevalence of childhood constipation, draw a diagram like what I did in that slide, and explain the nature and pathophysiology of fecal retention and development of constipation, and interpret the investigation results if you have done any, and tell them the management plan and follow-up plan, and discuss about the long-term prognosis. So the toilet training, if the child is having fecal withholding, there's no point of giving that child laxatives after laxatives after laxatives, because it's not going to be very successful unless you start toilet training. So stool withholders need to be toilet trained, right? They should be encouraged to use toilet after each meal and taking advantages of gastrocolic reflex. The proper technique of sitting and straining need to be taught. Now, there are evidence that it is playing a significant role in treating children with functional constipation. Fiber. Now, I agree. I told you low fiber diet is a risk factor for constipation. Now, that doesn't necessarily mean a loading high fiber diet is going to be very helpful in treating children with constipation. Now, there are several trials that has been conducted using various type of fiber in children. None of them was successful. So, high fiber diet is not very successful, or high fiber supplement is not very successful in as a therapeutic modality for children with constipation. Probiotics, several probiotics have been tried. None of them are very evidence-based. And so we don't recommend to treat children with constipation with probiotics. So that is still in the pipeline, I suppose. So how are we going to do fecal disimpaction? We generally, oral route is better than rectal route. So you can use high dose polyethylene glycol. It is effective in over 75% of children. It is less painful and less discomfort. So more effective clinically as well as economically. So the rectal route, we generally use rectal route only when the oral route fails. So I generally use some degree of sedation for these children because there's pain always there, and you can use enemas and suppositories to evacuate the fecal rectal mass. Once you cleared out the rectum, then it comes to maintenance therapy, aim to keep the stool soft to facilitate defecation with single or multiple drugs. You can use osmotic laxatives, stimulant laxatives, or novel agents like fluoropride or lubiprostone. So duration is variable, close follow-up and should be at least for 2 months, and then you slowly withdraw drug over 3 to 6 months. So closely follow up is essential to see whether they're going to relapse. Laxative for maintenance phase, you can use polyethylene glycol, which is the first choice. Very evidence-based. First choice is for pediatric constipation is osmotic laxative. Out of them, polyethylene glycol comes first. So very effective than others. Lactulose is also safe in a younger children. Right, magnesium sulfate has been used, and the sodium stimulant laxative like bisacodyl, sodium picosulfate, and senna. Now, these things cannot be used alone. Generally, we use them with a combination with osmotic laxative. Novel therapies like lubiprostone trial, which was concluded last year, which shows no therapeutic validity in lubiprostone in treating children, but there are several problems with this trial. Similarly, fluoropride trial has also showed not very useful for children. It's simply because both of these trials have selected a lot of children with refractory constipation. They had been on treatment for 2 or 3 years, and they have not considered so many factors. Therefore, both these trials failed. While these drugs, both drugs, lubiprostone as well as fluoropride, are very useful in treating adults with constipation. So we need more trials, more studies to really analyze validity of novel agents for childhood constipation. So what are the news, other techniques that we can use? The sacral nerve stimulation has come forward. Now, this is some between medical and surgical, I would say. So you surgically, insert electrodes to S234, which you know as well as I do, that innervates the rectum. So then you stimulate this with through a mechanical method, so that rectum gets stimulated and evacuates stools. So there are a few trials that has been conducted, but we probably need more data to assess them. This is a surgical procedure, and I think we need to be very careful because there are some complications as well in this method, but it's very attractive physiologically when you think of this sacral nerve stimulation. So sometimes you can use it for children with refractory constipation. What are the surgical interventions that we can do? We can do botulinum toxin injection to sphincter complexes so that sphincters get relaxed and facilitate passage of the stools when there is anal sphincter spasm. Antegrade continent enemas are useful. Surgical sigmoid resections, colorectal resections, subtotal colectomy, sometimes proctocolectomy and ileoidal anastomosis. That's a surgical lineup. So you can use whatever that suits for your child who is having refractory constipation. This is antegrade continent enema. You insert either radiologically or surgically. You use get a cecal button and a cecal tube and pump solution into the cecum through the tube so that bowel get cleared out, and that is very useful certainly in certain children with neurological handicap children who are having constipation. And you can regularly plan and evacuate the bowel, and they can be symptoms-free rest of the day. But there are complications like infection, granuloma formation, and tube leaks, and so on and so forth. Sigmoid colon resection. This child, actually one of my own patient who had presented to me with refractory constipation. When we evaluated, there was this dilated rectum. The investigation did not show any evidence of Sprung disease. So the help of our surgical colleagues, we took this part out, and initially child was there with the colostomy, then child started to grow very well, then we reconnected, and child is doing really well at the moment. The child came to me with severe constipation and failure to thrive. It's beautifully Now child has grown and doing very well. So you have to select the right patient at the right time to do this correct surgical procedure. What is the prognosis? Generally, remember this, however, right? They do not outgrow of constipation and need carefully planned treatment, right? Only approximately half of all children with constipation followed for 6 to 12 months after therapy were doing well without laxatives. Some children do struggle with constipation lifelong, right? Recovery rates were higher when they were treated by a pediatric gastroenterologist. Bad prognostic features include older age of onset, delay in seeking medical advice, and low defecation frequency. Now, there is a very nice research from Netherlands, which showing 1/3 of children and adolescents who had constipation as in childhood, grow into adulthood with constipation and IBS with constipation. So ladies and gentlemen, the take-home messages are constipation is a major public health problem across the world. It significantly affects lives of children and their families. Risk factors are highly prevalent. Routine investigation do not help in day-to-day clinical management. Multifaceted approach is the best way in managing children with constipation. Novel therapeutic options are available for children who are refractory to conventional interventions. With that, I would stop my lecture, and I would like to wish you a very best for the rest of the conference. Thank you very much.